Did you know that being tall or having extra long fingers isn't just unique? It can actually indicate that you're at risk for a life-threatening rupture of your body's largest artery. This reality is actually faced every day by those with Marfan syndrome. Hello everyone, today we're going to be taking a look at Marfan syndrome. My name is Allison Parsons, this is for Bio 211, Anatomy and Physiology. Now let's get to understanding Marfan syndrome. What is Marfan syndrome? It's a genetic condition that affects connective tissue. This is the material that helps to hold your body together and it keeps everything supported. It affects multiple structures in the body like bones, ligaments, heart valves, and even your eyes. It affects about 1 in 3,000 to 5,000 people. So while it is rare, it's not super uncommon. And the root of this issue is a gene called FBN1, which makes fibrillin 1, and this is a protein that is crucial for connective tissue strength. Most cases of Marfan syndrome are passed down in an autosomal dominant way. This means that only one parent needs to pass on the gene for the child to inherit it. But about 25% of cases happen from a new mutation with no family history. FBN1 is a large gene found on chromosome 15, and it makes fibrillin 1, a protein that keeps connective tissue strong and elastic. And sometimes people with Marfan-like symptoms don't have the FBN1 mutation. They may have changes in the genes like TGFBR1 or TGFBR2, which can lead to similar syndromes like Loeys Dietz or familial thoracic aortic aneurysm syndrome. So before we dive into what goes wrong with Marfan syndrome, let's take a look at how the body normally works and how these systems normally work. So in the cardiovascular system, which consists of blood vessels, the aorta is the largest artery in your body. And it's built to be elastic so that it can handle the pressure of the blood being pumped out of the heart. Within the heart, there are heart valves, which act like doors that open and shut while blood is being pumped out of the heart. These heart valves act like doors that open and shut just at the right time to ensure that the blood flows in one direction and doesn't back up. All of this works thanks to the elastic fibers in the connective tissue that give structure and strength to the aorta and to the valves. Now for the skeletal system, connective tissues also play a huge role here. They help with bone growth, alignment, and just overall structure. When everything is working normally, our bones grow in a balanced way, and our spine and our ribs and our joints stay properly aligned and they're supported. This allows for normal posture, movement, and flexibility. So what goes wrong exactly? How did we get from the normal anatomy and physiology to the anatomy we see in Marfan syndrome? Well, it starts with the mutation of the FBN1 gene, which causes the fibrillin 1 to stop working. And this protein normally helps to control a signaling molecule called TGF-beta. But when fibrillin 1 is defective, TGF-beta levels rise. Too much TGF-beta leads to inflammation and the release of different enzymes called MMP2 and MMP9. These enzymes break down connective tissue, especially in the aorta. This breakdown of connective tissue causes the aorta to stretch, which can lead to aneurysms or tears. And the mitral valve in the heart can also become floppy and cause irregular heartbeats. In the skeletal system, bones grow too long and don't stay aligned, which can lead to conditions like scoliosis and chest deformities. People with Marfan syndrome also have a tall and thin build with long arms, legs, fingers, and toes. This is called arachnodactyly. Even their eyes may often be affected. They may have lens dislocation and may be nearsighted. Now let's take a look at how the symptoms are related to the pathophysiology. All of these symptoms can be tied back to the weak connective tissue. The aorta weakens and expands because its wall can't handle the blood pressure. Bones overgrow because the tissue cannot handle growth. And the eyes weaken because connective tissue causes the lens to shift out of place. As for the treatments for Marfan syndrome, there is no cure, but there are ways to manage it. Medication like beta blockers can reduce the force of the heart's contractions and lower the blood pressure, which helps to slow down aortic enlargement. ACE inhibitors will block TGF-beta signaling, and this helps to protect the connective tissue from further damage. Surgery may also be needed to replace or repair damaged aorta or heart valves. A common operation like this will be the Bentel procedure, which is where the aorta or heart valves are replaced with a graft. Finally, lifestyle changes like avoiding strenuous activities are very important to reduce the stress on the heart and the joints. How exactly do these treatments work? The beta blockers address the pathophysiology by reducing strain on the aorta. ARBs target the pathogenesis by blocking TGF-beta activity, which is abnormally high due to the defective fibrillin 1. And surgery addresses all the symptoms and structural complications. Finally, lifestyle changes help to prevent system flare-ups and slow down the disease progression. So to wrap things up, Marfan syndrome is complex but is also manageable, and it can affect the body in many different ways. But understanding how and why this happens gives us the tools to treat it effectively. Thank you for listening.